Hi, I'm Dr. Vidushi from SuVi Eye Hospital, Kota, Rajasthan, and in this video we describe the pearls for implantation of Visian Toric ICL or the implantable colamer lens or a phakic toric IOL with CentraFLOW technology. The CentraFLOW technology is a proprietary technology which utilizes a small hole in the center of the ICL optic called the KS aqua port, which is to optimize the flow of fluid within the eye, and therefore the preoperative peripheral iridectomies or YAG PIs become unnecessary with this CentraFLOW technology. Our case was a 33 years old male who had a refractive error of -19 in the right eye with a cylinder of -2.75 diopter at 80 degrees and a refractive error of -14.5 diopter in the left eye with a cylindrical correction of -3.25 diopters at 110 degrees. This patient had a lot of trouble with his thick glasses, and even with the glasses he was unable to read accurately under all lighting conditions, etc. The preoperative workup is like for any other ICL. We do the keratometry readings, we do a full cycloplegic refraction, we do the corneal white to white diameter using a calipers, we do a complete eye examination, and we send this data regarding the keratometry, the refractive error, the white to white diameter and the anterior chamber depth to the company that manufactures the ICL. For a toric ICL, it is crucial that we mark the horizontal axis of the eye on the slit lamp before taking up the patient for the surgery. This is the eye being marked on the slit lamp preoperatively to put the reference marks, and these are the two horizontal reference marks that have been put. This is the printout of the summary of the toric ICL available from the company and the axis at which the ICL needs to be implanted. Once we take the patient into the operating theatre, using our reference marks that were put preoperatively, we mark the axis of astigmatism, and we also mark the horizontal reference mark with a little firm pressure to indent the corneal epithelium. The loading of the ICL is crucial, and this should be done before starting the surgery or before making any incision into the eye. We take this cartridge and we fill the cartridge with a combination of BSS and viscoelastic, as this combination of BSS and viscoelastic ensures minimum friction between the ICL and the cartridge during implantation. We then take this foam tipped plunger which is used to remove the ICL from its containing vial, and if there is any problem in removing the ICL from the bottle, we can slide the ICL along the sides of the bottle using the foam tipped plunger. This is the close-up of the toric ICL with the aqua port in the center of the optic, and then this ICL is placed into the open end of the cartridge. We have to ensure that the ICL is loaded correctly into the cartridge, that is with the correct orientation, ensuring that the holes in the ICL haptic are in the leading right hand haptic and the trailing left haptic, lining it along the side grooves of the cartridge on both sides. We then take a Visian ICL loading forceps and pass it through the narrow end of the cartridge, hold the ICL and pull the ICL anteriorly into the cartridge. During this, it is crucial to ensure that we actually slide the cartridge back rather than pulling too much on the ICL to avoid any tearing of the ICL. The injector is readied, and then the cartridge is placed into the injector and rotated into the snap lock mechanism of the injector. For the first few cases, it is always good, and the company also ensures that you have a company representative who will guide you through the loading procedure, as this is quite crucial. Once the ICL has been correctly loaded and placed into the injector, we then proceed with the surgery and make the paracentesis incision. So we make two side port incisions, just like for any cataract surgery. Fill the anterior chamber with 2% HPMC as the viscoelastic, taking care not to overfill the chamber too much. We then make the main incision, and now this is the ICL being implanted into the eye, taking care to ensure that the ICL opens slowly and in the correct orientation, and this ICL has to be implanted parallel to the iris, ensuring that the ICL is positioned anterior to the iris rather than placing it posteriorly, where there is a risk of touching the lens or hitting the anterior capsule. Once the ICL has been placed fully into the anterior chamber, we remove the cartridge and then ensure that the haptics of the ICL are tucked behind the iris. The holes in the haptic guide us to the correct alignment according to the astigmatic axis. After ensuring correct placement of the ICL along the axis, we remove the viscoelastic from the anterior chamber. During all our maneuvers of loading and implanting the ICL, we have to be careful that we do not do any maneuver that touches on the optic. All the handling of the ICL should be from the haptic or the junction of the optic and the haptic, and the optic should not be touched. And as is our routine policy for all cataracts and intraocular surgeries, we give 0.1 cc of intracameral moxifloxacin at the end of surgery. Postoperatively, the patient had a very good vision, and the vision was 6/5 and N5 unaided, and of course the patient was quite happy. This is an OCT image which shows the placement of the ICL, and we can see that there is a good vault and the ICL is placed nicely just above the lens. This is the second eye being done. This is a printout of the Toric ICL plan from the company. Again, the reference mark horizontal axis is placed on the slit lamp, and then the astigmatic axis and the reference are marked again at the operating theatre table. This is the foam tipped plunger that has been removed from its packaging, and again we fill the cartridge with a mixture of BSS and 2% methyl cellulose. The ICL is being removed from its container using that foam tipped plunger. This ICL is now placed into the cartridge, aligning it with the side grooves on the cartridge and ensuring that the correct orientation is maintained with the landmarks as provided by the company at the right leading and the left trailing haptic. The ICL loading forceps is then introduced through the narrow end or the barrel of the cartridge, and the forceps holds the ICL while the cartridge is made to slide gently backwards, so that the ICL is positioned in the narrow end or the barrel of the cartridge. The cartridge is then placed into the injector and rotated into the snap lock mechanism provided in the injector. Again, the two side port incisions are made. HPMC is filled into the anterior chamber, taking care not to overfill. And then the main incision, and we then implant the Toric ICL into the anterior chamber again in the iris plane, placing it just above the iris. The haptics are gently tucked under the iris, taking care not to touch the ICL optic at any stage, and the ICL is aligned along the astigmatic axis. We then inject pilocarpine and seal the incisions, and at the end we inject 0.1 cc of intracameral moxifloxacin into the anterior chamber. Again, the vision on the second postoperative day was 20/15 or 6/5 and N5 unaided, and the ICL was well positioned.
मेरा नाम राकेश अग्रवाल है। मैं एक शिक्षक हूँ और शिक्षक होने के नाते मेरा आंखों से तो गहरा रिश्ता है, क्योंकि बिना आंखों के कोई काम नहीं हो सकता। मैं काफ़ी परेशान था, जैसा आप देख सकते हैं मैं इस तरह का चश्मा यूज़ करता था जिसके काफ़ी ज़्यादा नंबर हैं। एक का तो -20, एक का -18, वो भी सिलेंड्रिकल नंबर के साथ। इसको लगाने के बावजूद भी कई बार मुझे कोई लोकेशन दिखाई देती थी, कोई लोकेशन दिखाई नहीं देती थी, और चश्मे का वज़न इतना था कि मानो बहुत सारा वज़न अपने ऊपर रख रखा हो मैंने, और इससे काम करना बहुत ही मुश्किल था। फिर मैंने कई जगह दिखाया, कोटा में भी कई जगह दिखाया, जयपुर दिखाने गया और भी कई जगह जांच करा ली, लेकिन मुझे कहीं सटीक उत्तर नहीं मिला, ना मैं कहीं संतुष्ट हुआ। फिर मुझे SuVi नेत्र चिकित्सालय के बारे में पता पड़ा, तो मैं यहाँ आया। मैंने यहाँ कई सारे टेक्निक्स के बारे में मुझे विस्तार से बताया गया, और उन्होंने मुझे एक नई टेक्निक टोरिक ICL के बारे में बताया। इस टोरिक ICL का मैंने अपने ऊपर प्रयोग किया, और आज स्थिति ये है कि मैं इससे मेरा विज़न बिल्कुल 6/6 हो गया है। इसमें कोई सिलेंड्रिकल नंबर नहीं है, न ही किसी प्रकार का कोई रिस्क है, न ही मुझे इसमें ज़्यादा आराम करने की आवश्यकता हुई। 2-3 दिन के अंतराल पे मैं बिल्कुल एक आपके सामने नॉर्मली पेश आ रहा हूँ, और मुझे कभी अब यकीन नहीं हो रहा कि मेरे वो चश्मा लगा था कभी। 476983570458 15926346728658794765127453 grouped together in 2s, 3s and 5s. Long and narrow with sharply pointed across soon became of this bent elbow with the coupled palms of his other hand.
So to summarize, the toric ICL can be used for patients of refractive error with cylindrical corrections who are not good candidates for other kind of refractive surgery. This case where we used the toric ICL was a patient of very high refractive error in both eyes and also needing a cylindrical correction. And after putting the toric ICL, he achieved a very good visual acuity post-operatively. The CentraFLOW technology now available in the ICL allows optimal aqueous flow within the anterior chamber, and therefore preoperative peripheral iridectomies or YAG-PIs are not necessary. And with the injection system available with the ICL, we can place the toric ICLs easily just like any other ICL and place it along the astigmatic axis to correct these high refractive errors along with cylindrical errors at the same time. Thank you.